Let's unpack the evidence because that's where the timing debate really plays out. And we all know EOLIA is often the centerpiece of the timing debate. And how do you interpret its main result is, of course, they say there was no statistical significant 60-day mortality difference was seen, but given the crossover to ECMO in the control arm too. So, uh, what exactly tells us? Do the per protocol or the sensitivity analysis suggest a signal towards an early benefit when it comes to the EOLIA?
The EOLIA trial is one of those kind. It's a unique trial in that it's going to be very difficult to replicate. They took about 10 years to complete it, and clearly, such trials are seldom heard of in clinical medicine. The only other trial I can think of is the DANGER trial for cardiogenic shock, where they used Impella. Coming back to the EOLIA, so the EOLIA, if you dissect it further, there were a few things which I think the investigators had a judgmental error when they started the RCT. So they were expecting a fall in mortality by using this protocol. They expected a fall in mortality by 15 to 20%. And eventually they achieved only 11% absolute risk reduction of mortality. And that's where it became insignificant. So if for the same trial, let's say Alain Combs were to redo it, and I was talking to him the other day, and he was telling me that I was a bit ambitious when I aimed for it. But if I had aimed for a 10% reduction in mortality, this would have been a significant trial. So going on to say that at the end of the day, the whole thing is governed by what statistics you use and what your judgment is
Yes.
about this particular disease. And that's where he showed that if you use a Bayesian statistics to analyze these same data, you'd find that EOLIA is a successful trial. Unfortunately, that is it's not the primary
Correct way of doing it. And
way of doing the secondary analysis later. And one other good thing that came out of the EOLIA trial is I think both Alain and Giles Peak from Caesar, they combined together to give us an IPD analysis, individual patient data analysis, and that showed clear-cut benefits with patients who needed ECMO. Again, going on to say that individual RCTs didn't do it, but when you sum it up, you have enough data now to show that ECMO works. And clearly, with your question of timing of ECMO, I think the EOLIA, what it showed was the patient who initially went on ECMO as per the trial protocol or the trial criteria, they actually did far better than the patient who crossed over late. Going on to say that patients who satisfy the EOLIA criteria straight away would be the ideal timing of ECMO. But that doesn't mean that if your patient has missed the boat, like how you were talking to me about late referrals, whether it is really worth trying going on ECMO or saying, hey, you missed the boat, thank you very much. But I think, what EOLIA was trying to say there was, even if they are referred late, yes, they'll have a higher rate of complications. They will have a higher mortality. They should still be considered, and it still works. So we don't have uh, uh, defined criteria as to when to say no in ARDS based on these trials.
so, of course, then comes the Caesar trial, which suggested, as you spoke, the benefits from transfer to the ECMO centers. And of course, the right time has not been defined, but rightly told by you when we prone the patient. This is how the ECMO centers, FL centers should be kept in the loop, and you decide how the patient is doing on the while being on the prone positioning. So, of course, Eolia told us about the initiation. And as you very clearly mentioned, if you look into the secondary analysis, even that the patient who were moved towards from control arm, still
Yeah.
the mortality was very high, but they did survive few of them.